I got to plug in. So with that, I think, are you on by any chance, John Jew? Are you on?
Yeah, Paul, I am.
Good. You have to get off at 11 Eastern. Yeah.
Yeah, in about half an hour, 20 minutes.
Yeah. Okay, I mean 12 Eastern or whatever. Okay, good. So I think what we should do is go ahead and launch into this thing. I'm waiting for I guess our main discussant to get on. So that's a little bit of a problem. And so we're going to get into this. But a couple of people that I'm trying to see if I can find Jason. I'll have to go chase him down, I guess, somehow at this point in time. Because he was supposed to be doing the presentation. So I'm going to look and see if I can track him down. So in the meantime, Bill, you'll be able to do a little presentation at the end, correct? Okay, so
Yep.
that would be helpful. Right now, let me go see if I can find him since he's supposed to be. I wanted to launch him on right now for John's purposes as well. Okay, so be patient. In the interim, let's see if we can get a report from somebody. Jim, why don't you go ahead and give us, because it doesn't have to take too long. Go ahead and give us, as I'm calling him, why don't you give a quick briefing on where we are on fluids and so on. Okay?
Good morning, everyone. CME is in the chat for both the groups. We are facing our third IV fluid shortage in 10 years, two of them due to hurricanes. And as you all know, this one has severely impacted large volume fluids. In our case, that means our resuscitation fluids. For those of you that are in the areas where your patients oftentimes have peritoneal dialysis, the PD fluids are unavailable, and D10, if you all will remember that. The shortage is really causing some significant problems for hospitals, and they are canceling elective surgeries in order to be able to restrict their fluid uses. That impacted me. I was in Boston running a conference. I had a lot of people with gastro, and the EDs did not want to use IV fluids for those people. And I have had at least two friends who've had elective surgeries that have been canceled. It looks like this shortage is going to continue for some time. There are relatively thin stocks of IV fluids within the system. It is more than other products, a just-in-time delivery system. And when this North Carolina plant got knocked out, and then for a couple of days there was a plant from a different manufacturer in Daytona Beach that was shut down to prepare for the next hurricane, Hurricane Milton. At this point, the Defense Production Act is allowing the feds to help Baxter restore the North Carolina plant. Nonetheless, this additional financial burden on hospitals by restricting ambulatory surgeries is going to have a financial hit. That on top of pandemic, on top of Change Healthcare, on top of no surprises, is yet one more blow to the acute hospital systems. And I just want to make you aware, since everything is very fragile in our healthcare system, this is another hit to them. From our perspective, we have reduced our use of IV fluids to those that need it. In the emergency setting, we don't want to try to play games reducing our use of fluids for people who are in shock. And so we have maintained that. We have restricted our fluids where possible, use smaller bags, because the 50 and 100 cc bags are not in shortage now. Those are the bags that are produced by Baxter in Puerto Rico. So it's the large volume bags. If we don't have to use them, we don't. If we don't have to waste fluids, we don't. So we've become much more clear. We're going to use IV bags with short expiration dates and save the ones with longer expiration. And there's a possibility that the expiration dates on certain IV fluids will be extended, just so you're aware. Anyone else have ideas on innovative restriction of IV fluids that they're doing locally that may benefit the rest of us? All right. We'll keep exchanging ideas. If I hear anything more, I will share it with everybody. Paul, thank you for the opportunity. and just remember what the impact is on your hospitals.
So, yeah, anybody else have any clever strategies that you've been using to face this, or what your plans are that you're making? And by the way, it's unfortunate, but I have about 20 people that are doing their shifts today, and we're missing out on a lot of the people who have done some innovations in that area. So, but I'm not going to speak for them at this point in time. It was interesting. Fridays ended up being a busy, got to do my shifts day. So it's kind of an interesting thing. So I may reconsider once again, what we're going to do about the schedule here. But for now, we'll stay in there. Well, I'm still waiting for our guest speaker to come on. Not
Hey, Paul, is that your production right behind your right shoulder there? Is that where you're producing IV fluids?
Yes, that's it. Yeah, it's it's canine based systems. Okay, that kind of thing. So we've accumulated 3 or 4 dogs because my daughter and son-in-law are off on trips up to the Northeast right now. So okay, so who posted the medical policy thing there? Is that you, Jose?
Yes, I just shared the sort of the approach that we have in a way that the state adopted. So it's in a policy document. I think I shared this with Peter and somebody else. Anyway, just putting here in case somebody is useful.
Yeah. Well, can you give us a 30-second nutshell, some of the salient features there? We're waiting for my guest speaker to come on.
No worries. Hey, good to see you all. Just sharing here pretty much what Jim already alluded to is trying to give some guidance about which patient populations you want to limit, obviously, the use of fluids. So we try to address it here in what I think is logical manner here from a clinical standpoint. And we have been able to conserve, I forgot right now the percentage, but we'll conserve, good amount of fluids. So we have enough supplies now that we can at least think we can wrestle with over the next, at least 30 days, 45 days or so. So anyway, it's pretty much straightforward. It's trying, like Jim said, sort of the population that is sort of not in shock and kind of give some guidance there. And so far it's been useful for us.
Okay. Hey, just as a quick FYI, as I'm like still trying to spin a little bit while we're waiting for our speaker. I may go on. Oh, Jason's here now. Okay, finally, we'll get on with him. Let me put him up here. I was going to say it's kind of interesting. We have our third at AMSP president on with us today. Jose is our current president. Doug is on, who is our incoming president, et cetera. And Paul Paris is with us. He was our third. And it was great. Paul and I hooked up again last night. And unfortunately, for the reasons of losing Ron, and we're going to have a little I think session about that next week. And but I told him you ought to get on with us and see how far we've not come. Right? Things are more the same today than they ever have been, right, Paul?
That's what it seems like.
Yeah, right. Exactly right. So good. Thanks, Ron. Jason, you ready to rock and roll here? I got to get going because I want to get some commentary from other people, if that's okay, right?
Sure, Paul. Sorry, a bit late here.
Okay.
Let me just log.
I think I introduced Jason last week. He's the chair of emergency medicine down at Broward Health in Fort Lauderdale, and gave a really great talk on our Florida Seagulls thing the other day, just bringing back the whole concept of a STEMI is not the only OMI, okay, meaning occlusive area. And so there's been a movement. I have some dissenters like Amal Matu might have some commentary about it. He couldn't make it today because he's on shift, by the way. And I might read what he had to say later on. But in the meantime, I want to at least get people to see what at least the controversy and or the concept is, and just to sort of introduce it. This may be deja vu all over again for a lot of you, but for some people, it clearly was something, good point. So I think it's worthwhile. Jason, if you don't mind, go ahead and head up. And then we're going to have Bill Baumer, who's in charge of doing QA for the whole northern part of California on who goes to cath labs and what we did there. And I'll have commentary for John Jew as well, because he's been working with this for quite a while. So hopefully we can get them all in before they have to leave at about noontime, your time, Jason. So go ahead, hit it away.
Thanks, Paul. So certainly I just want to clarify, I'm not the originator of this movement. I'm just trying to amplify the voices that are the originators of this movement. It's a paradigm shift in myocardial infarction. well, I'm just going to go over historically, how the term STEMI came to be and how we use that as the kind of the ticket that we punch to get someone to the cath lab. And I'm going to kind of cover why the OMI movement is better. I just posed a question to the group. Is STEMI a disease or is STEMI a disease marker? I mean, we certainly use the term as if it is actually a disease. We say this patient had a STEMI. But if we think about it in context of other things, like if I have a patient with right lower quadrant pain and an increased white count, those are disease markers. And the disease is appendicitis. If a patient has abdominal pain and an elevated lipase, those are disease markers. That patient has pancreatitis. If a patient has cough and pulmonary infiltrate, those are the disease markers for pneumonia. So the question is STEMI a disease or a disease marker? I would argue that it's a disease marker. It is a disease marker for the disease occlusive MI. And so we kind of only use that word STEMI to describe patients that should go to the cath lab, but we should really start using the term OMI because there are many, many other criteria we should be using that aren't necessarily ST elevation that should prompt emergent cath lab activation. And like I said, there's a lot of people kind of making waves in this movement. Dr. Pendle Myers is a big voice in this. Dr. Steve Smith is a big voice in this. These are various things you can find on YouTube, MRAP, MCRIT, Life in the Fast Lane, et cetera, talking about replacing the STEMI misnomer. The original document that came out was this OMI manifesto by Pendle Myers that came out, I believe, in 2018, and then it was followed up quickly by a MCRIT where they interviewed him and kind of went through it. And I encourage anyone to find that. You can find that on YouTube if you just search for OMI versus NOMI. But let's talk about it from a historical perspective. I'm sure there are several of you on the call that remember when things were Q wave versus non-Q wave MI until we reached the reperfusion era, which happened in 1994 with the publication of this article in Lancet. And this is when we were using lytics to reperfuse. But essentially, they said, we have this therapy now. Now we have to figure out who we apply this therapy to, because we certainly aren't going to send every chest pain for fibrinolytic therapy. So when they looked at EKG findings, they found that this particular finding, ST elevation, caused benefit. And if you gave lytics to patients with ST depression or a normal EKG, you actually caused harm. So that was the line we drew in the sand. If you had this one finding on EKG, you went for a reperfusion, at that time lytics. And if you didn't have it, you didn't. And then over the years, we just stuck to that line in the sand. We stuck to the term STEMI. And this is from Pendle Myers' presentation, by the way. I adapted it from that. But over the years, we changed the millimeters. We changed things from male to female, where V2 and V3 had a gender difference. But in general, we still stuck to this ST elevation being the ticket to the cath lab. So if this paradigm is the way we should practice, then every time we see ST elevation, we should find a complete occlusion. And every time we do not see ST elevation in a setting of an NSTEMI, we should see an incomplete occlusion. And that's not what really happens in real life. In real life, when we have ST elevation, 15 to 33% of the time, it's a false positive. Those patients have benign early repolarization, pericarditis, bundle branch blocks, LV aneurysms, LVH, et cetera, et cetera. What I'm more worried about is the false negatives. 25 to 30% of the time, patients with completely occluded coronaries are not presenting with ST elevation on the EKG. In fact, there's only about 25% of the time that you see ST elevation is it actually an acute MI. I really want to focus in on those false negatives, right? What does the literature say about this population? Right, what the patients that are false negatives, they don't have ST elevation MI, but we find in the cath lab later they have a complete occlusion. By the way, those patients have things we describe as De Winter's ST wave complex or Scarbosa criteria in the setting of bundle branch blocks, posterior MIs, which present as ST depression, hyperacute T waves, etc. So what does the literature say? What happens to those patients that don't present with ST elevation? Well, we double their mortality. Why? It takes us 10 times as long to get them to the cath lab. Right? They don't go as emergent cath lab activations. They go as NSTEMIs. NSTEMIs go to the cath lab, but 24 hours later, up to 24 hours later, and so it's a delayed cath. And that delayed cath means you have 10x more time to cath and you double their mortality. So how do we accept such poor performance? Well, we don't. There's a lot of really smart doctors out there They've been preaching about this for a long time, but we use these terms, STEMI equivalent, subtle STEMI, semi-STEMI, etc. You keep using the term STEMI to describe things that should go to the cath lab that aren't really truly ST elevation by kind of twisting ourselves in a pretzel, trying to get these patients to the cath lab with this flashy term STEMI. They're not really STEMIs. They don't have ST elevation, but they represent occlusive MIs. So, this is an example of an EKG of a patient presenting with a good story. I think everyone would agree there's inferior ST depressions here, 2, 3, and AVF, to just a hint of ST elevation in AVL. You'll see just a hint of ST elevation in V2. By our STEMI criteria, you need ST elevation and 2 contiguous leads. So if you're faced with this in your department, you don't really meet STEMI criteria. But in your heart of hearts, if you're faced with this patient, you believe this patient has an obstructive MI. But the cardiologist has every right to say doesn't meet STEMI criteria, and let's just get serial troponins and admit them, and you can put them on heparin and just treat them as ACS or an NSTEMI and delay this cath, and that person will be justified, right? There's no such thing as a false negative, because if he's wrong, we change the term to NSTEMI, right? This guy, he had an infarction, his troponin went up to 100. It's like, okay, well, it's an NSTEMI. He's right? And that way, there's no such thing as a false negative. If you call this a STEMI, or you call this an NSTEMI, there's no such thing here as a false negative. So the point that I want to kind of take away from this, and I can't give this whole talk, obviously, is that the underlying pathology should drive what we do with these patients. If we believe this patient has a complete occlusive MI, those patients should go to the cath lab. So what are some of the things outside of STEMI that should prompt emergent cath lab activation? Well, we know the modified Scarbosa criteria for diagnosing MI in the setting of a left bundle and other things. There's the Wellens reperfusion pattern. There's ST elevation in one lead, which I just showed you an example of there, where you don't have 2 contiguous leads. You have subtle STEMI, which I have several examples of, but we can't really get to in this talk. There's occlusive MIs that present with ST depression, like posterior wall MI or De Winter's ST T wave complex. And there's hyperacute T waves. The only thing on this slide that presents with ST elevation really is STEMI, and some of the modified Scarbosa rules present with ST elevation. So my take-home point here is time to bury the term STEMI and all of its friends, right? Semi-STEMI, subtle STEMI, STEMI equivalent, and let's start using the term OMI. And the new dawn will be, does this patient have an occlusive coronary occlusion that would benefit from an immediate intervention? So this should be the dawn of a new era. We look at an EKG, looking at it through the framework of the underlying pathology, an occluded coronary, not through the eyes of, do you have this disease marker, which may or may not represent an occluded coronary. Let's focus on the term occlusive MI. I'm going to stop here. I go into several examples here, and I can share a link to my entire talk, which is an hour long, but I just wanted to kind of get that point across.
Well, if you want, go ahead and share the link in there, and this is good timing because I got to move on to this real quick. I know that Chris Colwell, you got to go to a shift. If I remember, you're probably on at 9 o'clock today, right? So what anything to report out of San Francisco before I move on?
Unfortunately, not on at 9, but I have to start heading in at 9.
Okay.
Yeah, so we thanks, Jim, for the summary on the IV fluids, and we're struggling with that from a hospital standpoint as well, and have reached the point of canceling elective and even in some cases semi-elective surgeries in a means of trying to mitigate that. October being 5 weeks, we get our minimal or limited shipments every other week, but in a 5-week, that means we went 2 weeks without getting it, or will go 2 weeks without getting it. So we're in particularly short supply there. And unfortunately continue to struggle with fairly long wall times over these past several weeks, particularly in response to some of the city events. So the challenges in San Francisco continue, but we're at least we're safe from the hurricane stuff that has been hitting the other coast, and overall we're hanging in.
Okay. Hey, Chris, why don't you just give me a call later? Let's catch up on a few things if you don't mind, even after your shift if you want. Okay, that's it. Sorry to have interrupted.
Okay, for a little later today, I'll do that. Okay, bye.
Absolutely. See you later. Take care. Okay, so I just want to make sure we got plugged in there. Sorry about the dogs here. dog sitting can be something
I
else.
see a cat in the background too. Is there a cat
Oh,
there too?
there's cats, there's dogs. It's like, remember Ghostbusters, cats and dogs living together, right? So let's get on with this because we got John Jew, you have to go. So let's start with you. Reaction. Tell me about OMI in your land, right? And your perception of this. Then we'll go on to Bill Baumer. Okay. And I'm going to read some notes also from Amel that he sent to me. Okay.
Yeah. Jason, thank you for that intro. It's really good because we actually have been looking at that for a while. We have actually implemented the OMI within our region in 2024. Frankly, we have a little bit of confusion in our EDs right now with the terms, especially with our nurses of OMI. But on a one-on-one case basis, we have used it as a criteria for STEMI. Frankly, it's been a little bit anecdotal, but we've had a number of really, I would say, notable cases of OMI that our EMS crews have diagnosed. And frankly, we don't call it STEMI, but we call almost as we transmit the EKG, and it basically puts an alert there where we can call a cardiology fellow for him or her to actually make that diagnosis. So we have some growing pains with our interventional people. In other words, some of them obviously don't want to go to cath immediately, but they will actually investigate them with cath early within, I would say, arbitrarily 1 to 6 hours. I'd be very interested to see what Dr. Bonner has to say, because I think we've been watching that issue since 2022 when the American College of Cardiology came out with their paper. So we've been watching that. Back to you, Paul.
Yeah. So as a segue to Bill, it said here that, and for those who may not know, if you're joining us for the first time, John Jew has been there in Portland and the surrounding county for 97 years. I don't know how long it's been. What is it, about 32 years, John? How long have you been here now?
Since 1995 as well. So
Okay.
I think Chris beat me. I'm not sure. Did you?
Who?
Chris Caldwell. I think he beat me.
Okay.
Anyway, that's beside the point.
All right. But anyways, Amo sort of said to me, he said, why aren't we using the term STEMI equivalence? Because that's what ACC is already using, that term, et cetera, added to their guidelines in October 22nd. And he goes, why use a term that's unfamiliar to he thinks that might hold up, we get pushback from the cards and delays in adoption of new criteria compared if we just called it STEMI equivalence, but whatever. So that's a great question then to lead into the interventionalists or the people who are evaluating the interventionalists. So again, we all know Dr. Bill Baumer, who works for, part of his job is to work for the Department of Health there in California and evaluate the utilization of cath labs and so on throughout the state. But if I didn't get that right, Bill, explain that if you don't mind, and then go ahead and give us your reaction to this, okay?
Yeah, and I'm gonna share screen here for you in a second. And let me know if you can see my screen.
Looks like we can see a screen, but right now all we're seeing is like, oh, here we go. We're there at OMI and AI, okay?
Okay, all right. So,
Bill, tell us again, remind me what your particular title is with regard and function for state of California.
We oversee and review the primary coronary interventions, PCIs, in California, and I'll show you some of that data. And we oversee the elective PCIs in the state of California as well. We represent about 10% of the US volume for percutaneous coronary interventions at this time. But I want to give a little background from cardiology as to, and I very much enjoyed Jason's talk. I support everything that he said. And I just wanted to show you on the left that you've all had it in medical school, the activation potential. And what it shows is that it represents 90 millivolts on each cell. Each cell has a difference of potential of 90 millivolts from the inside to outside, represented and monitored largely by gaps that are shown on the right. And these junction gaps allow ions to pass from inside the cell to outside the cell. The entire current in a electrical cell is from the inside to the outside. That 90 millivolts of billions of cells adds up in most situations to cancel out, so that on the left was the original EKG showing 1 millivolt difference between one part of the upper chest on the skin and the lower part. So 90 millivolts times billions of cells adds up, cancels out in almost all situations, leading to 1 millivolt. On the right is vector cardiogram, the P wave in gray, the QRS in blue, and the T wave. And that's a vector cardiogram, which was introduced as a more sophisticated EKG years ago. But because it requires more leads, no one accepted it, and we are stuck with the old EKG format for that. And the EKG format, it shows that there is a pattern for an ST elevation MI shown on the right, going from ST being flat, no voltage detected, to being elevated. And notice the elevation of the ST is 1/10 of a millivolt in that situation. 1 millimeter is 1/10 of a millivolt. So we've gone from 90 millivolts across billions of cells to 1/10 of millivolt, and that's what we're measuring for the ST progression as it goes on. And on the left, it shows that if a cell is ischemic, it generates less potential that leads to the ST elevation that we see for the quote ST elevation MI. And on the bottom, our current criteria for ST elevation, as Jason pointed out, is a millimeter or 0.1 millivolt in 2 contiguous leads throughout the EKG, except in V2 and V3, where we have a little higher threshold up to 2 millimeters in individuals who are young men, a little less for women, and a little less for older individuals. That's the ST elevation MI that we see. And we can see from before that there's a lot of ways that 90 millivolts gets down to such a small area that we actually don't meet the criteria for 1/10 of a millivolt. And
Can I ask
in
a
the
quick question, Bill? Let me interrupt you. And how much of impact does body habitus have on that?
a lot. In other words, if you put the EKG farther away from the heart, as you saw in that first diagram, the voltage gets less. And if you don't have a good contact between your electrode and the skin, that's a resistance. Ohm's law suggests that the voltage goes down at that time. So you can definitely drop that voltage from a millimeter or 1/10 of a millivolt to half of that just by the resistance you see at the skin level. So unfortunately, there are a lot of ways to further reduce that and get below the criteria, meaning we get a lot of ST elevations that don't meet the criteria that are representative of a heart attack or an occlusive myocardial infarction in that case. So one of our most frequent diagnoses has to be with low voltage ST elevation, less than a millimeter in 2 contiguous leads, which is fairly common, about 1/3 of our cases where we'll see that. So in that particular case, we'll often repeat the EKG, scrub the skin, do other things trying to increase the voltage at that time. But that all takes time to accomplish. Now, how often does this occur? In the US, you can see the mortality rate from people with a myocardial infarction who never get to the hospital. They die before they get to the hospital. Fortunately, that 25% mortality that used to be in the hospital, we've reduced to about 2.5%. So a 10-fold reduction in it. In the bottom, it shows you for California, and in this case, for the year 2022, we had 30,000 primary PCIs in California, 30,000 cases came in, were diagnosed as an ST elevation or acute myocardial infarction, acute coronary syndrome, went directly as an emergency to the cath lab. That's 30,000 for the state of California. That's 300,000 per year for the US at that time. It is a very frequent diagnosis that we get for someone coming in with, quote, ST elevated MI, or in this case, the possibility of occlusive MI. How do we differentiate that? Well, our cardiologists look at the EKG. If we've got a little less than the required ST elevation, we'll repeat it. And depending on the clinical situation, we may electively decide to send them emergently to the cath lab at that point, based on best guess of the interventionalist at the time. There are also, as Jason pointed out, a number of other criteria, well-ins and with pacemaker or with a bundle branch block, where we'll make a uniform decision to send them to the cath lab without meeting the ST elevation criteria. We've always called these equivalent MIs or subtle MIs, and we've just said we'll do it. We'll send them to there to reduce their mortality, because their mortality going to the cath lab, as you can see in this situation, is 2.5%. Whereas if they don't go to the cath lab emergently, it's 5 to 10%. So double at that point in time. So I totally agree with Jason. We have used in the past, our interventionalists, what's called Queen of Hearts, AI, which is part of the process of his program, which is now a pocket guide that looks at the different mimics of myocardial infarction that are not ST elevation MI for it. The difficult we have right now is our interventionalists know all of these criteria. We receive 3 to 4 myocardial infarctions per day coming in. So this is common for them to review, and they'll have 30 or 40 cases, that they'll be looking at from the last week to review this. However, for someone who doesn't get 3 MIs a day, it is difficult to memorize all of these criteria and look at them at that point in time. In that case, the pocket guide, the OMI pocket guide, which is available right now, but not FDA approved, is available as a helper for those individuals. Our interventionalists have used on the left, the Queen of Hearts, which was an earlier model of it with AI to determine, and found it to be accurate at that time. So it is a totally accurate thing. The problem we have is our physicians do not want to document that they're using a non-FDA approved algorithm. As soon as it is FDA approved, then we have to talk about insurance on it. That is, if you made a decision on this and you said your decision was based on the pocket guide or the Queen of Hearts, what is the coverage for you if for some reason that makes a mistake at the point? Very important in California for malpractice at that time. So that's where we stand. It is a very useful program. I've gone through it. Our interventionalists have used it. There are no problems that I've seen with it at this time. It needs more work, development, and approval, and we have to get, at some point, insurance coverage for it.
So one of the questions that Jose has asked is that has anyone quantified, at a population level where you're working, the increase in cath lab activations that in this? For say, if you use the pocket guide or looked at these alternative things to get things moving along to the cath lab.
So what we currently do for insurance and malpractice is if we use it, the results get overread by a clinician. So then the clinician makes that decision. So on paper for malpractice, It's a physician decision going to the cath lab. Now, about 10% additional cases to 20% will go to the cath lab using the non-ST elevation criteria outlined by Queen of Hearts or the Pocket Guide. So there is a 20% increase, but it's not felt to be a problem. Those patients almost always have an occlusive myocardial infarction.
So then the next question, and if we can also, I want to get short, responses so I can get on to the rest of the audience. So one question I have is, let's go back to what Matu raises, the issue of that this may, if you start using different terminology, is that going to impede or delay or get pushback from cardiology? What do you think? It sounds like, based on what you're telling us, that it just is a matter of a learning process for all of us, right?
I don't think it's a problem. I think all cardiologists realize the problem is plumbing. So using occlusion relates to plumbing. And that's what we do when we go in with a coronary stent. We fix plumbing. So it's a plumbing problem that leads to an electrical signal that leads to it. So we're fixing the plumbing, and occlusion MI is more descriptive of the plumbing problem.
Hey, will you throw some kind of a link to the OMI Pocket Guide here to them?
Sure.
I think I had it before, right? But if you could do that for me while I'm running the meeting, I'd appreciate it. So let's go ahead and take you off the share. And then I wanted to go around the room, see if anybody has a reaction to it, their own experiences, how they like this, and then how do we translate. The bottom line is going to be now, how do we translate this to the paramedics so we can have earlier cath lab activation in some of these cases, right? So anybody have any experience and anything they want to add to that?
Yeah, Paul, I have a quick comment question.
Yeah, go ahead.
The question was, so Jason had mentioned this app, Queen of Hearts app. So I tried downloading it. I'm not sure if anyone has any experience with it, but apparently if you're in the US, you can't use it. And then Lou Steinberg, who happened to be on our Florida webinar call, he said that he asked for early access. And it's an app where you take a photo and it just puts it through the AI algorithm, and it tells you if you have OMI. And I'm wondering if is anyone using that beyond the Pocket Guide that Bill just spoke about? Because I think that could be the next iteration where that software is actually integrated into the Zoll and the LifePak monitor, so that we're not having to use another algorithm externally.
I think he addressed that by saying this has not been FDA approved. That's the holdup, I think. Is that the same thing, Bill, that you were referring to?
Yeah, I think for Zoll, they would probably not want to incorporate it until they had FDA approval. And this all relates to liability insurance.
Interesting.
Right, but the question is, does anyone have access to the app or experience with the app as a beta version? Who could say whether it's working or not? That was really my question.
Okay. Anybody? At least that's on.
Well, we have used Queen of Hearts, which was the earlier version of the Pocket Guide. And we have used it, and it has been effective. We have not used it on thousands of patients. We've used it on handfuls of patients.
Okay. Hey,
is that just like a PDF, or sorry, Paul? Is that Bill? Is that like when you say, is that like a PDF guide, or you're using an application?
Yeah, you can download it from the internet.
Okay. Hey, Russell, out in El Paso, it sounds like you had something there to offer us, a guide of some sort. Tell us about what you say about this. What's your reaction?
No, actually, I didn't have the guide. I just put the link into the chat so everybody could go to the OMI Guide website.
Have you used it yourself, or thinking about it, or now thinking about it?
Now thinking about it.
Okay.
Mainly for my fire guys.
Yeah. Well, the other thing is that, we talk about the insurance, we talk about all that, and maybe it doesn't translate when we get to the cardiology decisions. But yeah, I think just for us to get more sophisticated and learn more and be more sensitive and picking up cases, I don't see why we couldn't develop this on a more broader scale in our realm, and make sure our paramedics are trained indoor. Maybe like I think Peter's right. If we have a thing where you take the picture and then it tells us what it is, right? There's always problems with that, as we know. When you read the thing that says whatever at the top. But on the other hand, if that helps with sensitivity and specificity, I think that would be a really cool thing. Anybody else have any input or questions or reactions to all this?
Well, I think this is a great training tool.
Yeah.
And the reason is if I have to train someone to read EKGs, they have to read an enormous number of different EKG diagnostic patterns, etc. This focuses on literally occlusive myocardial infarction. So for training paramedics and others and ER people who are involved with the occlusive MI transfer to the cath lab, this provides, I think, a training tool, because if you go on the site, you'll see examples of different areas. So it provides a focused training that I think is valuable.
Okay. Hey, Jason, any reaction to what you just heard now and follow up to all the we gave you? Anything else you'd add, or what's your reaction at this point in time since you gave the main presentation?
Yeah, I think we're kind of at a threshold into kind of a whole new world when we're going to introduce AI into this. And, just like anything, when we introduce something new, like we have to be the spirit to ensure that it's being used appropriately and not kind of here to replace our own good judgment, our own good sense, right? I mean, I don't know yet because I haven't had a chance to play much with the AI models. If you can incorporate patient demographics and what the clinical scenario is and these other things, but they play a huge role. I think the AI is going to be a great tool for us, but certainly I don't think it should be the end all be all and make decisions and kind of replace us in our judgment.
Well, then one thing I could do is throw down the gauntlet in the sense that maybe this is something that we can even research, even as a group here, or for many of us, because then we can get some data on that, and that would maybe help move things along if things have not been, and it's interesting because it has so many other implications like politics and insurance and whatever else, all those kinds of things that in malpractice, especially, and so on. But I think it'd be worthwhile. So this is just good to stimulate the concepts here and all that. And I think I really thank both you and Bill in particular for for your presentations here today. Anybody else have any other reactions yeah, go ahead, Jim.
Yeah, we're combining a lot of concepts here, and we have to think how complex coronary artery disease is.
Yeah.
And when we have acute interventions, when we need to go to the cath lab, and what'll be covered under malpractice and state rules and all of that, we have indications to go for an acute coronary interventions, the same as we do for stroke. And going to a lab for one of those diseases is somewhat about finding the cause and then taking care of the implications when you found the cause. There are ST elevation events that occur around things like coronary artery spasm, but you can't stand over the top of the patient and make a diagnosis of spasm versus occlusive disease that is amenable to treatment of some kind. Right. And then there are people who have STEMIs who have had every intervention that they can have, and the cardiologist says, let them infarct because there's nothing more I can do. I've intervened in every way. They have critical disease at the end of one of their arteries, and we can't do anything further about it. And there's nothing that'll drive the medical records people crazier than you letting a STEMI evolve in front of you with no intervention done. So I'm just going to point out there's indications for going to a cardiac lab, and we need to respect those. And some of those relate to ST elevation MI that's obvious to us. Some of it is based on our clinical acumen. Thank you.
So the bottom line here so far today is that it just is mostly an awareness concept right now, and that it's complicated than we think. And so I didn't know if there's any action items for us or not. Peter, go ahead.
Yeah, so Paul, the question I have is that imagine today one of our crews brings in a patient who's a clear OMI, but the hospital that we transport that patient to does not take the patient to the cath lab. But let's say, like Jason had in his thing, 437 hours later, right? What do I do as a medical director, knowing that we called it in as an occlusion, it wasn't attended to the proper way? There's a rub there, right? So what would people recommend that needs to be done there? It's almost like we're telling the hospital that we have an LVO and they don't fire up the cath lab for that LVO patient. That would be not good practice. Would everyone agree with that?
Yeah, no, I understand. So the question is, what is it our obligation to report it to somebody or follow up on it? And where do we go? And that'll be an interesting discussion to have. So let's first start with Bill is going to give you guys, can you give a quick response, Bill? Because I have to get on to other topics.
Yeah,
I want to get Grino on and a few other folks that we haven't had on for a while. But go ahead, Bill.
Quickly, this I want to focus on, this is a single sign for a myocardial infarction, single sign. We spend a lot of time on high sensitivity troponin, which is also important in an equivocal case, and chest pain. So we'll make a decision just based on symptoms of chest pain or cardiogenic shock and make a decision for the cath lab. So not entirely on EKG. So both lab tests, high sensitivity troponin and chest pain are important for that. For the other comment of what do we want to be identified, we would like to know ahead of time in the ER when someone's coming in with an OMI, and the reason is we'll activate the cath lab. We have 6 cath labs available. We want to have a bed available in the cath lab if an acute myocardial infarction OMI is coming in. We'll clear the room, we'll prep the room, we'll be ready, and we may ship directly from the ambulance to the cath lab. So early alert is what we want in the hospital for that. We will review or confirm either the EKG findings as the patient enters the hospital, or if they are relayed to us by telemedicine. But we would like to know the alert so that we can get our lab ready for direct intervention. We try to get our door to balloon time less than 60 minutes in every patient, and we aim for 30 minutes. That 30 minutes means we have to be prepped and ready to go.
All right, Ben, go ahead. You don't mind making a comment then, Ben, out of Baltimore?
Obviously, we're not going to solve this here. This is a great discussion, but I don't think this is any different than what we've done previously. I mean, I remember when CPR came out, I had a couple of my paramedics listening to an Alma 2 podcast, and we would drive everybody to University of Maryland Medical Center and then drive the interventionalists crazy because it was not at all a STEMI or an OMI. So I think it's incumbent upon us to, number one, follow the guidelines. We have clear guidelines about this. For example, I think for posterior OMIs, I mean, those clarify for direct to cath lab. And I think that as medical directors, we have an obligation to say, hey, these patterns have high morbidity and mortality. I think getting them to the hospital, it's actually easier for us because whether the hospital activates or not, you know, that's on them. But at least we as EMS physicians can say these are patterns with significant morbidity associated with them, and then kind of raise the awareness that they should probably go to interventional centers. But I think we encounter the same challenges with stroke where, you know, there's a lot of over triage. There's a lot of post-arrest over triage, and all we can do, I think, is raise awareness about the high morbidity and mortality patterns.
Okay. Hey, since you're up, let's answer Peter's question where he goes, if you had someone that you feel like should have gone right to the cath lab, whether it was a stroke, LVO, or OMI, you know, who do you report to in your food chain? Do you talk to the hospital administrator? Do you go up somewhere in the health department? And what would you do is there an obligation on your part, in fact, to do that?
I don't know if there'd be an obligation, and obviously I'll do whatever Peter wants to do because he's much smarter than I am about that. But we actually have.
No, he used to be much smarter than you. Okay, that's why you asked the question.
We have a very good relationship with the area STEMI committees, and what I would probably do is if there's a concern articulated and not reciprocated so that we can make sure that there's expectations that are set. We would usually refer that to the STEMI committee and get follow-up from there.
Yeah. Okay, anybody else have advice about that? Maybe you don't have a STEMI committee where you are, okay. Jose, do you have any thoughts about that since you're the assistant city manager, right? So.
Yeah, no, this is very helpful and great presentation. Obviously, from a system standpoint, I was curious about sort of how systems will deal with simultaneous activations, right? Which are an issue, and you have more, and what sort of how it affects sort of your activities. But no, this is great information. Certainly, it's sparked some interest in me and having some more talks here with my community.
Yeah. Now, do you have, like, let's answer Peter's question where you got an LVO or you got a clear OMI going on and they didn't take them to the cath lab right away. Do we, as the medical director doing our quality assurance rounds or the paramedics complaint about this, who do we go to? Who do you report to in your area?
Yeah, so we have in our EMS sort of what we call stakeholder group here, we pretty much identify, but we look at every case that either didn't go, and then we do actually have a conversation with the medical director service line and sort of have a better understanding. And so we do have that back and forth communication, and sometimes there's a reason, or sometimes there's something that can be evolved into other improvement activities, but we do have that proactive conversation.
All right. Anybody else have anything to offer on that end? So before we start going around and checking in with everyone here today.
And Paul, just I want to answer, just follow with Ben's comment. Like we had yesterday, an 80-year-old guy on the golf course, double sequential them, got him back, and then he ended up with a STEMI, right? If a guy like that doesn't end up with a STEMI, but he's got an OMI, again, that's another issue we've had where and that's a whole nother reason, right? They don't want to get dinged for the death. And again, I know I don't want to open up a whole Pandora's box there, but that's been a whole nother issue where these guys won't take these patients into the cath lab because they're worried about getting dinged nationally on the websites, etc.
Oh yeah, and I think that's one of the things we brought up before we were talking about resuscitation centers, and that whole issue. The cardiologist didn't want to take the people with CPR progress, but you just in those given areas, you need to establish. That's a subgroup that you can't be held accountable for, right? So that just has to do with the committees within those hospitals, I think, and all that. So, all right. If no one else has any other things, Jason, any final remarks? It sounds like this was good. I hope the feedback is okay for you. If you're still there, I don't know if he had to go. He may have had to go.
I'm still there. No, thank you. I appreciate it. Excellent discussion.
Okay, good. And so nothing else then to add. We can close this one out and move on to other areas. So. All right. Well, I was looking around for Meg Marino. She was on, and I was going to try to get her on and all that. Let me then move on real quickly to some of the other groups, and then we'll head out. I want to go do rounds around the table of different cities. Let's first start though with a couple of people. One is John Kramer. Anything you know about on the blood end? We have a lot of former presidents of NAMSP on today, which is interesting, because Mike Levy's here, so it's great, and John here. So John, anything new to report on the blood end we need to know about?
Nothing overly significant right now. We're actually getting some inquiries and input from international folks who are interested in learning more about our programs as well. So otherwise, we're continuing to move forward on the reimbursement and starting some activities and better defining the business case. So hopefully that will address some of the data issues that we need.
Are we doing on whole blood to blood products on that end, the semantics, right? Anything?
Well, that's part of the continuing message, but nothing real significant.
All right, good. All right, thanks. Doug, anything out of NAEMT or any other organizations that you represent this week?
Well, I will stick to NAEMT. Jose is on for any comments on NAMSP, but NAEMT is, for me, it's an interesting time because I'm really winding up my last month or two of serving as the medical director. And for those who don't know, Vince Macesso is going to replace me. So stepped down because of taking over the NAMSP presidency. And,
Ah.
it's a conflict, but it's also a time commitment issue. So there are a number of reasons for it to make sense for me to leave that position. And Vince Macesso will be taking that in the end of December.
So this is it's quite a Pennsylvania thing then, right? Paul Parrish, you said that you're living right near Vince, right? Correct? Am I right in that statement?
Yes.
Okay, good.
Yeah.
We just finished talking about him. I didn't know he got.
Yeah. Well,
yeah.
Vince's time with NAEMT has been very extensive. I think he's been about
Yes.
close to 20 years or at least 15 or so as an involvement with AMLS. And so he's been very involved in some of their products and courses, and AMLS is one that he's had a lot of involvement with. So
Okay.
that's the only, I don't have a lot. I mean, it's sort of to some degree business as usual. There's some excitement about some new courses that I think are not quite ready for prime time to let everybody know about. But I think that many of the people that are members may be interested in being involved in some of the new course offerings that we're talking about.
And then you'll be taking the reins over sometime in mid-January from Jose.
At the end of our conference, at the end of the conference, which hopefully everybody is planning to go to in San Diego. It's always a crowd pleaser location, and
the Manchester Grand Hyatt is such a great hotel. I love that place. It's really good. So, all right. Well, that's good. And then that's a good segue to go over to Jose. That's a 2-year term, if I remember correctly. And that's what Jose's been doing this.
That's the memo that I got when I got signed on to it. So
I got to tell you, it's interesting because one of the reasons why I actually set that up to be a 2-year term years ago, because it just seemed like when we had 1-year term, people were just getting their act together on stuff, especially in the old days, and then they were gone, and you lost that continuity, that kind of thing. So anyway, I think it's worked out really well for us, as a matter of fact, so which is kind of cool. So Jose, anything to report out of NAMSP that we should know about?
Just briefly, a couple of things, and good to see you all. Obviously, we're all reflecting this week with the loss of Ron, our first president, and obviously we've been communicating and sharing with our members a little bit about sort of Ron's sort of impact, not only in emergency medicine but also in our industry, in our field. So we're working on some things to share more about sort of Ron's legacy. I don't think if folks knew, but Ron was also instrumental in sort of building some of the systems in Canada, in Nova Scotia. And he was also an elected official and a minister of health. So his leadership really transcended across many borders, and really an impactful figure in developing sort of the systems that we have today. So we've been this week obviously sad with his passing, but also reflecting on his great legacy and accomplishments. I don't know if you all noticed, but Justin Trudeau recently sort of reposted social media, right, reflecting on Ron's contribution. So anyhow, so that's something that
he did it in English and French.
And French, yeah.
His classic. Reminds me of that movie Canadian Bacon, where you have to have both things. It was great. So, but go ahead. I'm sorry to interrupt you. Those
no. So obviously, we have been obviously thinking about obviously his legacy, reflecting and sharing a lot of with our members and colleagues about his legacy. And I don't know if you all know this, but Ron recently, when he was recognized with the Order of Canada, he's one of the only 500 sort of individuals that have been recognized with that honor. So anyhow, I'm planning on going to Nova Scotia in November to his celebration. So if I see anybody there, looking forward to seeing you there.
You'll be seeing me there. So if you want to get some dinner or something, whatever. Okay, so that's good.
Yeah. And obviously, along those lines, I'll just add that we're getting ready for our annual meeting in San Diego, as already Paul mentioned. It's going to be a fantastic meeting, lots of activity and lots of things going on. And in the meantime, we keep doing all the BC work and advocacy and other things, but happy to provide more if anybody has any questions.
Yeah. Okay, good. I guess that would be it. And then Paul, you'll be able to join us next week to make some, if anybody was close to him, was Paul, particularly in the early days, especially relevant to NAMSP as well. Yeah, I think a lot of people, I wish Ray Fowler was on it right now, because I think Ron sometimes tells the story a little bit different than what really happened, but we actually were in a meeting in the Atlanta airport. I remember that rainy, cold night in November, and we said, well, how do we do this? We need to have a good leader. And we immediately thought the person who is the exemplary person in EMS in this country, it's well known, as Ron Stewart. So we called him up and said, hey, you just been made president of a new organization. And he was fantastic, because for a lot of the logos, a lot of the things we did first, the Caduceus, he actually started off originally with a purple color because he thought it was royal. And there's just all those kinds of things. He wrote the first bylaws, and he just was just an amazing human being. A lot of levels.
Paul, can I share something real quickly? And I look at John to hear. So Mark Wayne just sent me an email, I think this morning.
Yeah.
With a copy or a picture of his first certificate charter membership for NAMSP.
Yeah.
And it was pretty pretty interesting just to kind of see it. And
it's really cool. So good. Well, any event, we'll have more comment about it next week. I want to dedicate a lot of the time to Ron and all that. And Paul, you'll be able to do that. Mostly, I really want to have some kind of fun quips, about adventures that people remember. I think you were one that brought up the thing about going out to dinner, for example. But if you could bring some of those things up, that would be really fantastic then. Or maybe it was Don Yealy that brought that up. That's it. But any immediate thing you want to do to highlight?
No, I think next week will be a beautiful time to celebrate some of his memories and some Ron Stewart stories that are classic.
Exactly. That's what we really need. So that's good. All right.
For Paul, just a real quick supplement. Folks have been hearing for a long time that Ron was working on his memoirs, and they have now been published.
Oh.
They'll be released by, you can get them through Amazon and probably a whole bunch of other places. They'll be released next week on Amazon.
Well, then when we come back, can you do me a favor and make sure you can send us a link to that and so on? And that would be fantastic. So thank you so much. All that. Well, okay. Well, anyways, it is great sadness, but just the privilege of knowing him was just fantastic, let alone being a friend and all that. So it was really cool. All right, let's hop around the room. I'm trying to think, is there any, Jim, anything out of IAFC or IAFF that we should know about?
No, sir.
Okay.
Can I give a quip?
Okay, I want a quip. Yeah, give me a
1982, a medical student is interviewing at Pittsburgh.
Yeah.
And I came in without my A game. I gave a very embarrassing interview in front of somebody who's on this call. Paul Paris interviewed me, and I did lousy. And I was rescued by an interview with the other person in the office, who was Ron Stewart. And this many years later, I still remember embarrassing myself in front of Paul Paris and having Ron Stewart help me out. So thank you, Ron. Sorry again, Paul.
Yeah, I have that on video. I'll be releasing it next week.
That's fantastic then. Okay. Let's quickly go around the room. Let's start with the largest city, New York. Anything to report, Glenn? So
hi, good morning, good afternoon. No, the IV fluid shortage has been a problem for us as well. We're doing okay at EMS, but the state has put out an advisory with some guidelines and recommendations, just as Jose had sent for his area. More affecting us now is I had 2 hospitals call me to say that, yes, they have canceled all elective surgeries and such, but they anticipate running out of fluids by this Sunday. So they wanted total diversion starting Monday. And I said, we can't offer you total diversion. That's just not going to happen. They're going to have to do what they can. But that's kind of what's happening now. And I'm sure you're seeing that.
So that everybody should be, you're usually the what you call it, the canary in the coal mine, right? And so we should all be aware of that then. That's a good point. So total perversion, is that what you said?
Exactly.
All right, well, be aware of that. Now, last week you couldn't make the meeting because you were busy talking about Marburg, right? Anything
Yes.
out of that?
So, yeah, so as you know, CDC, effective October 16th, has filtered all flights coming from Rwanda into the United States to one of 3 airports. So JFK happens to be one, the other is Washington Dulles, and then the third is Chicago O'Hare. And so apparently there are no direct flights from Rwanda to the US, but somehow they filter through other areas. But so
Yeah.
before they get on a flight, Rwanda, the health ministry screens them. Although that happened in Ebola too, and it didn't really help because the thermometers in hot countries,
Right.
they don't work. But anyway, so they go to one of these 3 airports. Apparently about what do they say? 450 passengers from Rwanda come to one of those 3 airports. We get about 120 a week, I think it is. And we're getting about 30 passengers per day. We have not. So CDC quarantine will evaluate them, do a screen. If there's any suspicion, moderate to high, then they'll contact our city health department, who will contact us for transport, ideally to Bellevue, which is the Region 2 biological containment hospital. But we know that if they're sick, they're going to go to the closest to JFK, which is Jamaica Hospital.
But you're right that a lot of them not going to come. They're not going, and most of them are not going to come straight for Rwanda. There are flights that are going to go up to Frankfurt or London and so on before they head over our way. So I was wondering if that's something that could be marked, though, say in a ticket, that we did have someone who's a connecting passenger that came out of there. Hopefully they have that. Either way, I think the bottom line we talked about last week, we did talk about this because Eileen, Dr. Smarty, got on and gave us a little bit of an update on it. And the bottom line is that in our dispatch protocols, in our EMS protocols, almost every case we have that's a sick person, we should just basically be asking any recent travel, anything out of the country. I like to know recent travel, period. And then that should be just part of the whole approach to it on a day-to-day basis, as far as I'm concerned. Okay.
When we had Ebola, we did add the FT, fever travel. So if somebody said they had fever and they traveled to one of the suspect countries, we're not ready to pull that trigger yet. But any JFK case, so that our hashtag and everybody responding knows, we're going to add the FT suffix so that they at least know that they should get their PPE ready and be on alert.
I told them last week that Mike Osterholm had told me in May that be aware Ebola's coming, and I said okay, and we did activate that at that time, and that's how we picked up on the case. Our troops are the ones that picked up on that by asking that question, all that. John, go ahead.
Just in follow up to that question that you raised, the CDC and Customs and Border Protection have very aggressive protocols of following itineraries and identifying those folks. Certainly there are some that may slip through if they do a multi-city trip and things like that. But typically if it's from Africa to a common airport and then to the United States, they're identified.
Okay, got it. All right, well, that's good to hear then. But again, someone's going to slip through somewhere like they did with Ebola. Hey, let's move down 95 if you don't mind. Anything out of Baltimore that we should know about? Anything new happening there?
Hey everybody. Nothing really new to report. Still working on our nurse navigation. Lots of stuff going on with the opioid restitution funds that are happening. So the fire department has been given a seat at that opiate restitution fund table. I think there's a real good question about what to do with that. I had a great conversation with Detroit. Thank you, Dr. Dunn, about they had a contract. They contract with Third Service for post-opioid response stuff. So lots of good dialogue in that space. And as always, happy to learn from best practices in the group.
I'll pass it on to him. He's in the emergency department today. And he had told me because he said he was going to try to pipe in, but I guess he has not been able to. So anyway, so I'll let him know. So great. Thank you so much then. Let's go over to Jacob. Jacob, let's what's happening in Denver?
Couple updates. So we just had a meeting yesterday with the Denver Fire and the paramedics starting to rethink how we're doing response times. We've for years and years just done NFPA, and as our city grows, call volumes go, traffic, we're starting to rethink that. They just announced a urban sort of redevelopment of the area around our where the Nuggets play and the Avalanche play, which is going to be just like another 12,000 people in high rises. So we're starting to think through other ways to do response time, and so we'll probably work to get a survey out and just see if other folks are doing tiered, if they've come up with other plans. So Shay and I will kind of work together. And other kind of news, we're doing a little bit of hiring. We have a cool position open that is sort of a little bit of a liaison between all of the public safety agencies in Denver, as well as the division. And they're housed at Denver Health, but really work with Denver Fire, Dispatch, and us to work with quality. So that's open. And then we have an associate medical director position open too. So excited to just be sort of getting my feet under me a little bit and working with Shay to help our system.
Hey, so do you take people who are over 75 years old?
Absolutely. It's totally open.
Hey, so listen, quick question for you. You asked me about your fellows. Did they get on, or are you all set on that taken care of?
Yeah, I believe they're over on the attendee. Brent Hurt and Lakota Cheek are listening in.
They are. They
Had
are.
a great
Okay, good.
fellowship year.
Good. All right, good. We should put them on the spot and have them make presentations sometime, right? See what they were learning. Maybe towards the end of the year. How's that? Okay. Sounds
I
good.
did warn them of that possibility.
And Brent's from Baltimore, is what Brent is saying, right?
Yep.
Okay, good. All right. Hey, okay, so let's go over to the fire department medical director there. If that's okay, Shay, anything else you would add to what we just heard out of Jacob?
No, that's perfect. Yeah, we're excited to kind of revamp some of our response time considerations and really kind of looking at kind of overhauling how we report things that matter to us more than what might matter to city council, like the times or what they care about, and trying to focus shift their focus, I should say, to more of a broader experience, right? Of like patient satisfaction, STEMI times, cardiac arrest survival, things that actually are clinically relevant. So we're working on kind of a real big overhaul on that. So we're more to come.
I should refer you back to something that Brett Myers put together, I think about 15 years ago, where we said, here are 5 or 6 things that are good markers to look at, time to aspirin or, whatever it might be. There was a lot of, I just remember they had some markers that they used at that time, that maybe you could read. I'll see if I can find that article and we can revamp it and bring it back up to you. So that'd be good. On the response times, what are you thinking about, going to a tiered ALS BLS system or not, something like that?
Maybe even parsing it out further with our EMD, with how our response times are parsed out based on an Echo Delta call versus a Bravo Alpha call, and kind of looking at that. So
okay. Interesting. Yeah, it was interesting because the paradox was that when David can give you more data, David Purse, we moved from like 36 all ALS units down to like 12 ALS units and the rest being BLS. We paradoxically improved response times to the advanced calls because, or what they call it, Charlie, David, Echo, whatever they're called, because they're more available as a result, that kind of thing. Because nowadays before that, they were just tied up, picking up people, transporting them to the hospital, being tied up there and going back to their territory and all that. So it'll be interesting to see what you come up with there.
Absolutely.
Okay.
I think we're going to work on some sort of survey with the group to kind of see what others are doing and see if there's some best practices out there that we can incorporate.
Okay, good. Yeah. And we'll run that through Jim. We'll put something together that will just make it simple. Think about if you were on the receiving end of such a, survey. Okay. That's it.
Sounds great. Thanks, Paul.
Then Jim was good to say, remember today's CME was 19,440 or 19440. And for those who were on the Seagulls call, it was 41. Okay. Thanks, Jim, for putting that out. I really appreciate you doing that. Okay. Let's see who's on my list here next. Let's see as I move down the list. Libby, anything to report out of is it still dark 30 out there or getting brighter?
No, it's 6:45 already. So
okay. All right.
Pretty stable here. Not much to report. We're just watching. We keep getting these onesie twosies of Mpox and dengue from travelers, but that's about it as tourism ramps up.
Okay, good. I was hoping that, well, maybe we'll get a report next week. I was gonna help have, I thought it'd be nice, I hope she could do it maybe next week, or maybe it won't be. Next week we'll be busy, so the week after, but Eileen was talking about maybe doing a report on some of these E. coli things, and particularly about STEC E. coli, you know, like the ones that cause hemolytic uremia and all that. And so I think that'll be a kind of a fun thing just to remind everybody about that. I think that would be really kind of cool. And so, all right, let's see, let's move on down. Let's see. Hey, since I just saw your name there, Matt, anything else you could report to on more on the statewide thing?
Maybe me. Hey, Paul. Good afternoon, everybody. No one else. Nothing else really to report here. Just doing all the stuff.
All right,
and trying to move forward. Yep. Thank you so much. Yeah.
All right, good. Jim, anything out of Lee County we should know about, either out of Fort Myers or Cape Coral?
We start our blood administration, our whole blood administration next week, and picked a whole lot of that off of the rest of the Eagles. Thank you all.
Yeah. Good. Any particular, what's happening at the hospitals and how are you funding it right now?
We will fund it by initially buying the 4 units we'll put in service. Then we will either, if we use them, we will charge the patient. And if not, Paul, we have developed a way at 2 weeks with recorded temperatures. The blood bank will take the blood back, and then they will spin it down to components and use it. So we don't waste any, and we don't waste any money. They threw us a little bit of a curveball last week, or 2 days ago. They said, we only want to start with trauma patients, no medical or OB.
Okay.
So in a very busy system, we see bleeding, red stuff coming out for a variety of reasons. But at this point, we're only going to be able to put red stuff in if they're a trauma. And that's because of the hospital's requirements, since we're using their blood.
Well, get that video of our young lady with the tonsillectomy, right? We should do that. Yeah, because
I know.
Nothing like that. It's really. I'll try to send you a copy if you don't have one. So
I have a copy. I used it. The blood bank has said we're starting with trauma only, and after a couple months, if the pilot works, so this is all good language for those of you who haven't done this yet. Pilot first with trauma patients and with our trauma center. Then we will move it to all of our campuses, and we will have all of the issues addressed.
I was just with Lakshmi, and it's just amazing how many shootings they have in Atlanta and how much blood they've given. It's just been fascinating. Hey, let's talk about other people who are avoiding the wasting of blood out in Colorado Springs. Go ahead, Stein. Anything else to report, and tell us a little bit about your system now, how it's up and running. You there, Stein?
Yep, I am. Sorry, it just took me a second to find the mute button. Our blood system is up and running. We just hit over, I think, our 100th unit about a week and a half ago, which was awesome. We've had some really good saves. We had a really good advertisement of a full-term placenta abruption that was a definite save a few weeks ago. And Jim, I can send you some of that information if you just want to keep it in the background. There's been a lot of news reports about it also. Otherwise, I just wanted to mention, on the heels of Shay and Jacob, just south of you guys, we've been running now our tiered response based on time responses for the last 2 years, and have excellent data for that. And I'd be very willing to share that with you and give you any lessons learned. We're just going to be expanding that program. We're past the pilot stage, and we have 3 areas in the city, the most busy areas in the city, that we've been running the alternative prolonged response times. And we're going to be expanding that to the entire city.
So when you say things, are you saying that, for example, you're improving your responses to the advanced, to the critical calls? Is that what you're saying?
Well, what we did was we created several units that have prolonged response times. And so we went through every determinant, and we didn't do it just, Alpha, Bravo, Charlie, but we chose the ones that we thought could have a much longer response time. and
Got
then
it.
brought those out. Yep.
Okay, good. All right, thanks. Anything else then? That sounds like, oh, that's good then. All right, well, thanks a lot. Let's see what, there was someone else I wanted to hit up real quickly. If I can. Let's see, Ben, Andy. Okay, well, let's just, hey, Angus, are you on by any chance? Can you give us a report either out of, the Pinellas or in Tampa Bay area and or the state of Florida, since you're the medical director for the state?
Yeah, sure. So here in the Tampa Bay area, we are still very much in a recovery mode. Our sheriff was on TV yesterday announcing that he'd arrested hundreds of people for trying to scam local people doing repairs and all that kind of stuff.
Yeah.
So we have a lot going on here. A lot of people whose lives are completely disrupted. EMS volume, like normal, has been staying high post-storm. We're still above our normal 911 volumes. I think our rolling 14-day average is like 600 plus patients transported each day. So that's like 100 more than normal for us.
Are the hospitals able to accommodate that? But that's the other issue. That's the dead
No,
end.
we're holding everywhere.
Yeah.
We do a very active distribution of patients when we get into that mode. So we actually assign destinations when we go into that mode. Every unit has to call in and get assigned a destination hospital by dispatch to manage the flow. So we did that for about a week and a half, and we just turned it off the other day. So we're doing okay there, but it's really busy here, still in the post-storm deal. I do also want to say that since Jim brought it up, I also vividly remember making a fool of myself in front of Paul Paris early in my career as well.
Okay, good. That's fantastic. Hey, Angus, then about anything else across the
Don't
state?
believe
So Jim's obviously been keeping us up to date on the IV shortages. We're looking at that at the state office as well, and we'll have some discussion about that at our state meetings next week down in Naples. Hopefully I'll see you there, Jim. We're having, since Paul is on, it's also worth noting that our Florida Center for EMS, hosted at the University of South Florida, will be premiering at our state meetings next week. We have established a Florida Center for EMS in the spirit of the Center for Emergency Medicine of Western PA, in the spirit of the Maryland Institute for EMS and a few other folks. And we're trying to copy that down here in Florida, and that'll be a main topic of discussion at our state meetings next week.
Cool. That's
Congratulations.
Great. See what damage you've done over the years, Paul?
That's amazing.
More bureaucracies being set up. No, it sounds fantastic then, Angus. So that's really good. Well, good for you. How about your home? I know you got kind of trashed just on a personal level. What's happening there?
I moved into a little apartment last weekend, so I do not live in my home anymore.
Okay.
We will see what comes of that, but it's going to be a long process either way.
I'm just so sorry for you. That's all I can say. All right, well, good. All right, let's just move on down. I'll just go on. Andy, anything else we need to know, or anything is going on in the DC area since Bitburg's not on? Anything you could tell us that you know what's going on in DC or in your shop?
Hey, nothing new to report. I'm at Outpost Cody, Wyoming this weekend for my mom's 90th, but
so, glad you have her genes, right? Right. So that's great.
I'm not gonna lie.
Okay, good. Thank you.
Just a lot of school up right now for the election stuff, but I don't want to speak on behalf of FDN or DC Fire or anything, but just obviously lots of planning mode stuff for the next couple of weeks.
Sure. Yeah. Okay, got it. Yeah, but that's helpful. I get the idea there. Okay, good. Let's see, Doug, anything you need to tell us about at this point in time, or do you think we covered everything from your end?
Nope, all good for me.
Okay, good. Good for you. Thanks a lot. Eric, anything to add on to the blood situation or your own area if you want to tell us?
No, so I mean, we're up at 185. Jim will probably be 186 or 187 when they come on. The ABB meeting went really well. There's a lot of good comments. So I think those communities are getting closer together, and so that's amazing to see where this process has come to.
Give us a concrete example of a lot of good comments.
So I would tell you that probably 2 years ago, the average blood collector, blood banker didn't know what an EMS person was. And
Yeah.
so basically I'm doing a presentation with myself, Dr. Holcomb, Dr. Yeager, who's a blood transfusionist, physician, and then Audra Taylor from South Texas Tissue, and use that as an example for the folks in the room to reach out and speak to their local EMS agency. And a lot of folks came into the microphone on behalf of both their blood bank and EMS agency. So it was pretty good to see that structure moving forward.
Got it. Okay, thanks then. All righty. Then let's see. There was so Roger, anything you could give us out of your county?
Yeah. So good afternoon, everyone. I think I chimed in for a short period of time last week with some news about the blood, but I may have forgotten to throw a couple of things out that I thought were interesting. The first thing is that we have 7. So we're 2 months in. We have 18 units and 17 patients. Only 3 deaths, including 1 that made it to the OR additionally before not making it, and that would have probably been a traumatic arrest. So that's a success. So really, 2 deaths out of 17, which is not bad. Our shock index, one of the best cases of improvement in shock index is around 61%, and our mean, I think, for shock index approval is between like 38 and 39. But what was interesting is one of our best saves was a GU bleed, like really horrific hematuria, which is which is kind of interesting and unusual.
Not common, right? Yeah.
Yeah. So really, we really are very encouraged by including the medical patients, and so
you bleed an elderly male or what?
yes.
Okay.
Yes, it was a GU bleed in an elderly male.
So there you go, Jim Augustine. You can take that one to the bank.
Roger, what did you say about shock index again? I'm sorry, I missed that.
So our mean, I have Chief Scott helping me. We're doing a office move, and Chief Scott was reminding me because he's managing the database. Our QM manager was saying between 38 and 39% average improvement in shock index, with one of our best being about 61%.
Wow.
So extrapolating, that would be about something over 100 units a year. But with about 1 million people, it made me wonder when Stein was speaking of Colorado Springs. I thought his program was relatively new, but he's reporting over 100 units. Did I make a mistake about how long you've been up and running, Stein? Because it was 100 in something less than a year, given your population, that's a lot of patients. So maybe I can get with Stein and find out whether I can clarify how long he's been up to reach 100 units by now.
Okay.
Yeah, and one other thing I was wondering if I could throw out there, and that is, we're going to be new, and we've touched base with Ben Weston. We're going to be new with the hypertensive disorders of pregnancy for July of 25, which is the cycle for our protocols, where the units are going to be having access to labetalol. And one of the things we're debating is whether there's a sweet spot in other applications of labetalol. We're aware of Delaware and West Virginia and maybe some other states that have labetalol for a non-pregnant hypertensive indication, but some are maybe reporting that they're regretting it because they have medics a little overzealous and treating asymptomatic hypertension, which obviously isn't evidence-based. I was wondering if other folks in the Eagles group have a labetalol application for hypertensive disorders, acute, very high blood pressures, perhaps with end organ target symptoms, and they're happy with their protocol, and that it would be something that might help us just determine if there's an application for Maryland too. And that's what I was going to throw out to you, August. Thanks so much.
All right. Well, it's noon here at Central Time and time to shut down. Terry, anything out of Tucson or anything to report from your end?
No, nothing from here except one road rage shooting, and I had a procedure canceled. That's it.
Okay, thanks. Thank you very much for filling us in. That's good. All righty. Well, anybody else have any last minute things to pipe in? Joseph, anything from your end? If not, time to shut the thing down. Go ahead.
Real quick, thanks to everyone for supporting Western North Carolina.
Okay. I don't know.
It's ongoing.
Yeah. All right. Got it. All right. We'll keep that in mind. The people like Joe Holly and all that. A lot of those people that were actually there are actually in the emergency department working today. It was a busy day for them. All right, it was funny. Paul Paris said he had a boat up the street just sank and had to go off to check it. That's really funny. All right, well, things are, like I said, things are more the same today than they ever have been. That was actually, people thought that was a Yogi Berraism, but it actually came from Dwight Eisenhower, just so you know. All right, so with that, and no, anything else from anybody else? Otherwise, I'll say welcome back, my friends, to the show that ever ends. Next Friday, November 1st, we'll be in that mode, and we have salutes to Ron Stewart. We have some additional talks about the concept of needle thoracostomies, and we're going to talk about there's a couple other things, the handling of the conventions. If we have time, that'll be really kind of a fun thing to hear about as well, those Republican and Democratic national conventions. And with that, hopefully nothing else major happens in the interim, so we'll let you all go. Thank you very much. Take care. And we got the code was 1441. Yep.